Hello and welcome to the University of Washington Cardiometabolic Echo Session 2. I'm Nicole Earhart, one of the adult endocrinologists here at the Diabetes Institute. And we're really excited today to have Earl HIRSCH, a nationally and internationally known diabetologist, and actually our favorite endocrinologist here at the Diabetes Institute. He is going to be talking to us today about individualizing glycemic goals. Additionally, we have our expert panel to include Lorena Wright, an adult endocrinologist here at the University of Washington and the director of our Latinx Diabetes Clinic. We have Savitha Subramanian, an adult endocrinologist and also our resident lipid expert. Finally, we have Gail Bland-Newlundy, who is the director of the Diabetes Institute at Howard University in Washington, D.C., and also an adult endocrinologist. So without further ado, take it away, Earl.
It's hard to prioritize which topics are more near and dear to me, but this is one that has certainly changed over the years and over the decades now that we have much better tools. And I guess I should say, in prefacing this, when we talk about the goals and the therapies and the tools, is that probably the most important tool, and we keep talking about this because it is so obvious when people see it with their own glucose levels, is the whole issue of diet and exercise. And we have understandably become so excited about our new medications that we use. Nobody's more excited about these options than I am. But at the end of the day, understanding how different carbohydrates impact blood sugars differently than protein and fat, and how exercise, in fact, impacts glycemia, is a big part of the equation here. These are my current dualities, and let's get started. Multiple choice question, and I'm very curious, we're not going to have any formal polling on this, but to understand goals of glucose, how does one actually measure glycemia? Is it fasting glucose? Is it frequent home blood glucose monitoring? Is it hemoglobin A1C, or is it CGM? What's interesting to me is that this has changed over the years, and maybe there is not one right or wrong answer. What's interesting to me is that when I was in my training back in the early 1980s as a medical student, for most people with type 2 diabetes, it was a fasting glucose. And in fact, to this day, that has remained an important outcome in registration trials for the FDA, as new drugs are put through development to get approval. Fasting glucose to this day remains a goal. But I want to actually talk for a moment about hemoglobin A1C. This study was published, first author David Nathan. It's called the ADAC study. You can see it was published in 2008. We were actually one of the 11 sites around the world that was part of the study. And what we did was we used very early primitive CGM devices, which we put CGMs on people without diabetes, with type 1 diabetes, and with type 2 diabetes. And we put them on individuals for 3 consecutive days over 3 consecutive months. And what you can see here is that an A1C of 7 would give you an average glucose of 154, an A1C of 9 would give you an average glucose of 212, and so forth. And in fact, to this day, many labs show these average glucose levels from this study in 2008 to interpret what that A1C means. The problem with this, and this was noted in the second table in the article, are the 95% confidence intervals for these people. I need to point out, to get into this study, one could not have kidney disease, one could not have liver disease, one could not have anemia. In fact, one could not even have a high reticulocyte count, because that would kick them out of the study. So these were people with pretty much perfect hemoglobins as far as hemoglobin is concerned. But note that an A1C of 7 means that you had an average glucose between 123 and 185. Yes, the average is 154, but there's this wide variability. And you see this with each level. And in fact, with a hemoglobin A1C of 9, It can be as low as 170, as high as 249, which means you can have somebody with an A1C of 7 and an average glucose of 180 having a higher average than somebody with an A1C of 9 and an average glucose of 175. The reason for this is most likely related to differences in red blood cell survival. This was my beginning of trying to figure out, is this really the best tool for glycemic targets for our patients with diabetes? So the takeaway from this study is one can't compare A1Cs between two people. Each A1C comprises a wide mean glucose range. Now, A1Cs are great for a population, but if you're looking at Mr. Jones across the table and you say the A1C is too high and we need to add a drug, is that actually the case if you have somebody with an A1C of 8 and they have an average glucose of 150? Maybe not. It does not take away from A1C use in a clinical trial, because all of these limitations that you see here, these are all washed out if you're doing, whether it's a clinical trial or you are just looking at your population of patients in your clinic. This is a really important study. This was done by my colleagues, Doctors Bergenstahl and Beck. And the point here was looking at the differences in A1C for any given glucose between African Americans and Caucasians. And what was found, interestingly enough, and we already knew this, is that for any given glucose, African Americans, the A1C level is about 0.5% higher, between 0.4 and 0.5% higher. And I can tell you here in my clinic in Seattle, I have patients who consistently run 1 percentage point higher than their continuous glucose levels would indicate. But note, for example, for an A1C of 8, if we look at all comers, we have some people with an A1C of 8 with an average glucose here in the 120, 125 range. And for the same A1C, they have an average glucose well above 200. And so an A1C doesn't tell you about this variability of just the means, let alone the highs and the lows. So what I think it's important for everybody to understand, including patients, because they see this when they're using CGM, is this concept of glucose management indicator. And it was very interesting how we got this term. All this is, it's the estimated A1C from the continuous glucose monitoring, from the CGM. And it comes in an equation. The equation is done either on the download or on the app, but you can see based on the glucose levels what that A1C should be. And this was done with a more modern day CGM than was done in the David Nathan paper. So the GMI is a metric calculated by CGM-based formula from a population of mean glucose. And what patients know is that this is simply estimated A1C. It is on most, but not all of the downloads that we use. You can also find this on all of the CGM apps. Why is this so important? We actually looked at this with 641 patients from our Diabetes Institute here in Seattle. We looked at CGM data on a Dexcom for 25 days, and hemoglobin A1Cs were measured here at the University of Washington within 30 days of the CGM download. And the question is, how well does the A1C and the GMI match? And as it turns out, not as well as one would expect. Now, as opposed to the David Nathan study, where everybody had to have a perfect hemoglobin, in this study, we included everybody, whether you had anemia, kidney disease, liver disease, we included everybody. And so for any average glucose, you can pick whatever it is. You have huge variability in terms of what that hemoglobin A1C actually is when it is measured by the University of Washington laboratory. So if we then go ahead and compare the CGM discordance, comparing the laboratory A1C from the GMI, only 11% of our patients did the GMI or the estimated A1C match with the laboratory A1C. What was more interesting to me was that 50% of the patients, the discordance was more than 0.5. So if the estimated A1C based on the CGM was 7.0, half the patients were either above 7.5 or less than 6.5 with their actual A1C. Whereas if the estimated A1C was 7%, what we found was that 22%, the discordance was more than 1%. So if the GMI was 7%, the actual A1C was above 8 or below 6 in 22% of the patients. And I want you to think about this when you're thinking about using A1C as your glycemic target, because we know, and we certainly saw it in our study, that there was increased discordance with CKD. The more severe the CKD, the lower the A1C reads. I think the point is that whether you're at CKD, liver disease, or anybody, there is a huge amount of variability, which makes me question, how can we use A1C as a glycemic target if we don't know what the discordance is for that person's A1C? Now, if you have somebody who does not have discordance, using A1C as a glycemic target makes sense to me. But at least in my view, you need to know if there's discordance or not. And if you are seeing an African American patient, I can tell you the A1C is going to read high more often than not. And if you are seeing any other ethnicity patient, we actually don't know how they run differently because those studies have not yet been done. Now, I will tell you as a rule of thumb, when you're using continuous glucose monitoring, one of the many reasons a time in range of 70%, time in range, which is defined as 70 to 180 on the CGM, it's close to an A1C of 7%. And this is one of many studies that show that. But again, look at the huge amount of scatter in the data with time in range with A1C. And this, of course, is a huge problem when looking at A1C. The way I think about it is that A1C was a biomarker that we started using in the 1980s because we didn't have CGM yet. It was an important biomarker. All of our complication studies are based on A1C, but it's a biomarker for glucose. Now we can actually measure glucose if patients are able to get access to CGM. And as time goes on, more and more patients are able to get that. So A1C works great for a population, but not for an individual in patients for assessing glycemic control. So when thinking about targets, one has to realize it's much more complicated for macrovascular complications than for microvascular. In macrovascular disease, we're dealing with 9 different things. I'm not going to go through them with you, but all of these are responsible for macrovascular disease. But I do need to point out that glucose control is certainly part of it. It's just one part of a more complex physiology. Microvascular, it's much more simple. You have genetics, you have glycemia, and you have blood pressure when we're talking about, in particular, the eyes and the kidneys. So if we move now to 2022, when we think about type 2 diabetes therapy, yes, A1C lowering is important. Yes, safety for hypoglycemia prevention is also important. But now, because of what has happened with our cardiovascular outcome trials, cardiovascular disease prevention needs to be an important part of thinking of glycemic targets and drug use in type 2 diabetes. This all became very interesting in 2008. You may remember Dr. Nissen, the cardiologist in Cleveland, who had real concerns with rosiglitazone causing more cardiovascular events. What the FDA said after Dr. Nissen's publication is that to establish the safety of a new anti-diabetic therapy to treat type 2 diabetes, sponsors should demonstrate but the therapy will not result in an unacceptable cardiovascular risk. Now, this is the quote, an unacceptable increase in cardiovascular risk. So it's okay if you lower the A1C, that's what we want, but not at the expense if you're going to have an increase in cardiovascular risk. That was the FDA's concern. So what happened after that, and there were a lot of people quite upset about this, but the FDA said for any diabetes drug, and actually this happened with several of the insulins too, one had to have a cardiovascular outcomes trial. We didn't just have one, we had a lot of them. In fact, some of these are still ongoing. There will be more. We now know that we're not going to be getting as many of these cardiovascular outcome trials for new diabetes molecules, but this actually turned out to be the best thing that could have happened. The reason why this was so important is that we now know that these drugs don't actually harm, but some of these drugs do a tremendous amount of benefit, not only for people with diabetes, but also people without. So we have all of these different targets that we can use for treating type 2 diabetes. And we use all of them for different drugs and different therapies, which includes exercise. I just want to take a moment here looking at the SGLT2 inhibitors, which has as its main mechanism of action increasing glycosuria. And just looking at the major adverse cardiac events, or MACE, with the SGLT2 inhibitors, when you look at this meta-analysis that was just published last year, what you see is this reduction. The hazard ratio was 0.9. It did not cross 1. So you had this 10% reduction in overall major adverse cardiac events when you look at all of the different SGLT2 inhibitors. But where these drugs really have had their greatest impact is with heart failure. These are people with previous atherosclerotic cardiovascular disease and even patients without. For both of them, you have this, again, reduction of hospitalization for heart failure. And in fact, most of the trials show a 30 to 35% risk reduction for hospitalization. And that has been consistent with all of the various SGLT2 inhibitors on the market. Even more interesting with the SGLT2 inhibitors, both from a secondary endpoint and Canvas trial primary endpoint, is that these drugs have renal benefits. And these renal benefits are profound in terms of preventing decline in renal function for the need for dialysis or transplantation. And these drugs are particularly beneficial in people with albuminuria, more than 200 milligrams per day. What has become also interesting about the SGLT2 inhibitors from a renal and heart failure point of view is that these drugs have also been shown to be beneficial in people without diabetes, which is also quite interesting. So we're not going to go into any more just because of lack of time about the SGLT2 inhibitors, because I now want to talk about the GLP-1 receptor agonists. They work at the islets, both at the alpha cell with glucagon and suppressing the glucagon, improving beta cell function with insulin. It may be their greatest impact, especially in terms of weight, is with the CNS and the brain. They also do cause a reduction of gastric emptying. So gastric emptying is slower, so one doesn't see the postprandial spike. If we now look at major adverse cardiac events in this meta-analysis from last year, a different meta-analysis, we again see this reduction of MACE. The hazard ratio was 0.86, so a 14% reduction in these adverse cardiac events. They also have a beneficial effect for cardiovascular death. Any reduction is beneficial. This was a 12% risk reduction in this meta-analysis. The signal is consistent. As you know, besides lowering glucose, these drugs have a tremendous impact on weight loss. The key components when we look at the most recent American Diabetes Association and European Association for the Study of Diabetes, this is the ADA equivalent in Europe, when we look at the treatment of hyperglycemia guidelines, And this is, again, it needs emphasizing. All people with type 2 diabetes should be offered access to ongoing diabetes self-management education support. That's DSMES programs. This goes without saying for every patient, and not population, but every individual needs to have access to this. Facilitating medication adherence should be specifically considered when selecting which drug are you going to pick. Very important. GLP-1 receptor agonists and SGLT2 inhibitors for cardiovascular and renal benefit for people with type 2 diabetes should now be considered independently of baseline or target A1C. I want to repeat that. These drugs, based on the evidence, should be considered independent of the baseline A1C. So if somebody is already in target and they require a stent or they develop heart failure, these drugs need to be added no matter what the A1C level is or what the glycemia level is. We keep talking about target A1Cs, but I again want to make sure you appreciate that the target A1C may be different from one person than another based on their glycemia. GLP-1 receptor agonists are now the first-line injectable therapy for type 2 diabetes. It's not insulin anymore. It's the GLP-1 receptor agonists. These drugs have been shown over and over again to lower the glucose levels equivalently to when starting basal insulin. What they also do is they don't cause the weight gain we see with insulin. They universally cause weight loss. So if we now look at the algorithm and just go through this just for a moment, the first line therapy depends on comorbidities, patient-centered treatment factors, including cost and access considerations. We're going to get to cost in a moment, and management needs, and generally includes metformin and comprehensive lifestyle modification. Now, notice what it says this year. It generally includes metformin. It may not always include metformin, especially if somebody really needs to go on to a GLP-1 or SGLT2 inhibitor first. So this is where we start. If somebody does not have atherosclerotic cardiovascular disease of high risk, heart failure, or CKD, if they don't, we go down one pathway. If they do have one of those, then we look at these factors individually. If they have atherosclerotic heart disease or indicators of high risk, then the recommendation is to start with the GLP-1 receptor agonist with proven CVD benefit or an SGLT2 inhibitor with proven CVD benefit. I will tell you that for this particular population, I will generally pick a GLP-1 in this situation. These patients are generally obese, and the data as far as classic cardiovascular disease, whether it's TIA, a stroke, heart disease, peripheral vascular disease, the data is so consistent with the GLP-1s. In this situation, I will usually start that before an SGLT2 inhibitor. If the A1C is above target, there is nothing wrong with adding another one, adding the other drug. So if you start with the GLP-1, then going ahead and adding the SGLT2 inhibitor. And I want to point out there's a lot of very positive data with pioglitazone for the stroke patient in particular. If somebody has already had a TIA or a stroke, the pioglitazone, which a lot of people have forgotten about, these drugs have proven evidence of efficacy in preventing a further event. For somebody with heart failure, the data is quite clear about the SGLT2 inhibitors. And I do want to point out that the GLP-1 receptor agonists have not been shown to be efficacious with this population. Now, for the CKD population, the data is accumulating. I want to point out that there is a study ongoing now, which should be completed by 2024, called FLOW with semaglutide. That will be a primary endpoint renal disease study with the GLP-1 receptor agonists. Right now, the way the guidelines are written is that if they have CKD and albuminuria, more than 200 milligrams per gram creatinine, preferably we're going to start with an SGLT2 inhibitor. The reason for that is that all of the GLP-1 receptor agonist drugs in these situations have been secondary outcomes, not primary outcomes yet. On the other hand, if somebody has CKD with or without the albuminuria, CKD without albuminuria, and eGFR less than 60, we're going to come on down here. In this particular situation, either the GLP-1 receptor agonists or the SGLT2 inhibitors are recommended equally in this situation. And obviously, if glucose targets, and I don't want to say A1C targets, but if glycemia targets are not met, then you add what needs to be added to get the glucose levels down. On the other hand, if you don't have these issues with atherosclerotic cardiovascular disease, heart failure, or CKD, and the A1C or the glucose targets are above target, then we're going to use a drug based on which of these three different issues are most important for that patient. If you're going to minimize hypoglycemia, this is very common in a lot of our elderly patients. I'm going to be more interested, and this will be really the only time I would be interested in a DPP-4 inhibitor. I would more likely use a GLP-1 receptor agonist, an SGLT2 inhibitor, and for the very resistant patients, certainly the thiazolidinedione. As a rule of thumb in this population, we are going to avoid sulfonylureas or basal insulin unless we have to. As far as minimizing weight gain and promoting weight loss, here we are going to start with the GLP-1 receptor agonists. The two weekly ones we have now, I should point them out, dulaglutide and semaglutide. The weight loss data for this has been quite interesting, quite fun for our patients that we see. In fact, the 2 milligram dose of semaglutide was just recently approved by the FDA. I am told it will be in the pharmacies next month. We're going to use the GLP-1s or the SGLT2 inhibitors where you do get a little weight loss, not as much as what we see with the GLP-1 receptor agonist. Then, of course, if you're above target, you will do what you have to do, leaving insulin unless you absolutely need it to the very end here. And then for cost and access, you're just going to have to use whatever generics you can get. Now, it should be hopefully within the next few months, we're going to have the federal insulin cap at $35 if that can get through the Senate and then the president signs. Right now, as we speak, for most people, you can now get cheaper insulin analogs, and that's a whole other discussion how we do it. I still think they're too expensive. They're more than $35 a month. You can still get human insulin cheaply at Walmart for $25. I don't like using a lot of sulfonylureas, but this is the time I'm going to use them when somebody can't afford anything else. This actual graph, which we actually first published in 2011 in the Annals of Internal Medicine, and the ADA took it out and is using it. I think this is really important when thinking about individualizing glycemic targets, more stringent versus less stringent, and all the different things to think about with individual patients. Hypoglycemia, how long have they had their disease, life expectancy, comorbidities, established complications, patient preference, resources, and support system. All of these are on a continuum. And that's why having one A1C target, one time and range target for the CGM patients for everybody is not right. You have to look at this individually before deciding what is appropriate. If you have somebody who has a 5-year life expectancy, that's very different than somebody who may have a 50-year life expectancy, a young adult with type 2 diabetes. We are going to treat them very differently as far as their glycemic targets are concerned. I want to just make this point about cost. This study came out last year. As you can see, the costs of these drugs, this red line, which did not get caught here, this is the average total payment to the pharmacy. And notice what really caused the biggest amount of problem were the GLP-1s and then the SGLT2s as far as how much this costs. But I think what's important to realize, and this is the average, the out-of-cost to patients, now this is commercial insurance, the out-of-cost to patient really hasn't changed. It stayed the same. I think this is really important. Now, this is not insulin. This is everything but insulin. So the cost to the patients have not changed, which this was really surprising to me. The increasing costs of the launch since the launch of the DPP-4 inhibitors, GLP-1s, and SGLT2 inhibitors were 88, 78, and 37% respectively. It's the DPP-4s. Remember I said I don't use these very much. Those are the ones that have really cost more, but the out-of-pocket costs to the patients were relatively stable. So I want to just show you when we look at race and ethnicity, some of the problems are that I see. This was a study that came out last year looking at SGLT2 inhibitors. The overall use was relatively low, but the use was lowest in the Black and in the Asian patients. These were statistically significant. If we now look at a different study of GLP-1 use by a cohort of people with type 2 diabetes, again, by race and ethnicity, by subgroup. If we look at the overall cohort with type 2 diabetes, this type line here is metformin. More use of metformin. There is a somewhat increasing use of the GLP-1s, but the trajectory was not what it was with metformin. If we look at race and ethnicity, what you see here is at the bottom, it's the Asians who do the worst with the GLP-1s, and the whites do a little bit better. If we look at heart failure, where these drugs really have proven benefit, and remember, we saw our first heart failure data in 2015, we see very little use compared to what I think we should be seeing. When we just look at overall high cardiovascular risk, again, we are underutilizing these drugs as recently as 2019. Now, one of the things that I can say, at least here in Seattle, is that access to these drugs have gotten much better in the last few years. And what my hope is that as time goes by, these lines will come on up because they have the proven efficacy that I showed. So I want to conclude that for individuals, but not populations, A1C as your glycemic metric can result in problems. And that's the reason why it's my view that at least once you should put a CGM on a person to see if their A1C has discordance or not. Even just one time when you first meet that patient, sometime in that patient's lifetime. Because unless they develop an anemia, they develop liver disease, they develop CKD, most of this is genetically based, red blood cell survival that they inherit from their patients. And you don't know what that A1C means unless you do a CGM. The etiology of macrovascular complications is more complex than microvascular disease. Lifestyle is still the cornerstone of type 2 therapy. I don't want to forget that. In fact, this may be bullet point number 1. I made it number 3. Data has emerged that for heart failure, CKD, atherosclerotic cardiovascular disease, SGLT2 inhibitors, and the GLP-1 receptor agonists should be used early in therapy. Glycemic goals, whether it's time and range from CGM or A1C, they need to be individualized. In fact, the actual goal for the time and range for our elderly frail patients is really not so much the time and range, but minimizing hypoglycemia, minimizing the time less than 70. And I think that's more important than actually looking at an average glucose with an A1C for those individuals who have access. And like the GLP-1 receptor agonists, we are seeing better and better access to the CGMs. When hypoglycemic agents are required, the fundamental goal is as low as possible without disabling hypoglycemia. When I say as low as possible, we are now again back to A1C, where we're talking about time below range. We really want to minimize that. So with that, Nicole, I thank you all for your attention. I hope I brought up some points that was interesting for your audience.
Thank you, Earl, for that great lecture. I'm going to ask Gail if there was any questions that came up in the chat during the discussions that she wanted to highlight and answer live. Also, if there was any questions she wanted to pose to you, and if anyone else has any questions for Earl, go ahead and chat them.
I saw in the chat that there was a question on how do you counsel cardiometabolic risk in the 20 to 30-year-olds who may not know about or see the long-term complications, and that has been a challenge in that group.
Yeah, we face this every day. And it's a great question because it's not only the diet and the exercise and then the resulting obesity, but then the smoking and the drinking, a lot of times we see in those patients, and it's hard. I don't have any answers. I don't have any magic bullets. I think having family support in general is really important for not only this, but for all patients who struggle. I saw a young patient, really an interesting story. I met him when his mother brought him in because he wasn't gaining weight. Well, he was misdiagnosed with type 2. He actually had type 1 diabetes. And I saw him back today, and he's now married, and I hadn't seen him in about a year. And what I'm going to do with him when he comes back, and he's going to come back soon, is he's going to come back with his wife, because I do better with these people when we have family involvement. We have an adolescent young adult clinic that Nicole works in, and we have psychology available, psychiatry available. I can't tell you how important that is for a lot of these young people. You ask a question I wish I knew, because when I look at the obesity rates and the diabetes rates in these young people, it's just astounding. I don't know if the numbers are sustainable. There aren't enough of us to take care of all of them 20 years from now.
There is a question about the 2 weeks when you put on a professional CGM and you only get 2 weeks of data. How useful is that?
It's very useful. My friend actually did the study, and he did not use the Libre, they used the Dexcom. But what they showed was that a week did not correlate with A1C at all. 10 days did okay. But once you got to 14 days of data, it was no different between 14 days and a month. So if you have 14 days, assuming that it wasn't a time somebody was sick, they went on vacation, that type of thing. If you have 14 days of data, that is actually as good as a month of data.
Great points there, Earl, and thank you, Gail. One thing I wanted to mention about like counseling people, sometimes just mentioning that cardiovascular health or good fitness when you're younger actually equates with best cardiovascular health as we get older. Then I think it's very real when people see that their family members have developed diabetes, and talking to people about weight and cardiovascular risk, we are seeing earlier development of diabetes. I think that can be very real and a tangible thing. Also in our women population, the risk for gestational diabetes, because I think most people want to have the best pregnancy possible. So that is another tangible thing to talk about as well. Peter, go ahead and start the case.
Hello, everyone. I'm presenting a gentleman who's been a patient of mine for a couple years. I met him during a hospital follow-up visit in 2020 after he had been admitted to the ICU with severe COVID pneumonia. His pre-existing diabetes had been greatly exacerbated during that hospitalization, as it had been with the subsequent treatment that included steroids. So this gentleman, just to go through his situation, he does have insurance. It's a Community Health Plan of Washington. That was a barrier for him because when he lost his employment, he lost his Premera Blue Cross, which was giving him much better access to treatment. He's a 55-year-old gentleman. He's proudly born in DF, Mexico City. He moved here about 20 years ago. He's looking forward to moving back. The main kind of concern that I bring up with him is persistent hyperglycemia in him, in spite of being on basal insulin as well as mealtime short-acting insulin. His past medical history includes hypertension. He's been seen by our cardiologist here at CMAR and does not have heart failure. He has hypertriglyceridemia. He has an elevated BMI of 42 at the last check. And he has this history of severe COVID, which has left him with a persistent ambulatory oxygen requirement by nasal cannula and has led to disability. He did also have bilateral pulmonary emboli during that hospitalization, which necessitated anticoagulation for a 6-month duration, and he's finally off of that. For his medications, he is on Lantus. My colleague recently increased his dose, I think, from 35 up to 40 units at bedtime. He takes Humalog anywhere between 4 to 15 units 3 times a day with his meals. And he told me lately it's usually between 8 to 12 units. So 8 would be the minimum that he gives himself. Metformin, he's on a full dose of that, 1,000 milligrams BID. That had been reduced during his hospital stay, and we got that back up to the full dose. He is on sitagliptin, what is that, Jardiance, 50 milligrams daily. He's on atorvastatin, 80 milligrams daily. He's on losartan, 25 milligrams a day. He's on Lasix, 80 milligrams a day. He uses an albuterol inhaler. He's on daily low-dose aspirin, and he uses gabapentin as well. He doesn't have any allergies. His family history is just significant in his mother. She has both heart failure and hypertension. She lives in Mexico. So that would be his family history of heart disease. He is unemployed, and at the time when I submitted this form, his SSI was pending, but then I did check back in with him late last week, and he said it actually came through. So now he's getting SSI benefits, which is great. He completed 12th grade down in Mexico. Prior to this, he was working, I think, doing siding on houses prior to his illness in 2020. He is married. He said he's never smoked. He has never drank alcohol, doesn't use any recreational substances at all. And down to his kind of measurements, his weight is 135 kilograms. This gives him a BMI of almost 43. His blood pressure at the last visit was in pretty good control on his losartan, 132/72. He doesn't have any tachycardia going on. And for his labs, a few of these are, his glucose levels are from just a month ago. His random glucose was 374, and his A1C that day was 11.3. 3 months prior to that, back in December, his A1C was around 14. And his creatinine was normal back in December. There's his cholesterol, 173. This is on his atorvastatin. His LDL is nice and low at 82, HDL 42. Triglycerides were in the 240s back in December. His urine studies, albumin was 80. His LFTs were normal back in December. And then some other labs showed a BNP, our cardiology department acquired, which was 13 normal. And then his metabolic panel was notable for these findings, which were all in the normal range. Like his sodium was a little bit low. He's not up to date on his foot exam. He's up to date on his retinal exam as well as his depression screening and dental visit. He has received self-managed education. He has in his history. I did look back and saw that he had canceled both of his prior visits scheduled with our registered dietitian. He has been referred to them, but hasn't followed up. Then some of the social services pathways, barriers that he has, so his disability, his immigrant status, and his medicine pharmacy access. I bring that up because I had prescribed him a GLP-1 RA, I think it was Trulicity, yeah, I prescribed that, and he hadn't been able to get it. I think it was the pre-approval process that I hadn't dug into very deeply, so that's one thing that was a barrier. Now he has this disability related to his pulmonary fibrosis from the COVID, presumably. His typical meals, he says he eats all of his food at home, and he does do green juices, which his understanding is that those are good for his blood sugar control. He says celery juice that he makes himself. For protein, he'll get eggs, other greens, so spinach and cactus leaf. He drinks coffee without sugar or milk. And then lean protein at lunchtime, more vegetables. He's aware of trying to limit his simple carbs. He gets just one tortilla or one slice of bread. He eats quinoa, potatoes, or squash, one of the three usually. He'll eat apples for his snacks, or he'll blend those into his juice. He'll have a salad with lettuce, cucumber, 1 to 2 eggs, he said. He'll eat almond butter, drinks water and the celery juice in the evenings, or he'll have tea without any sugar. That was a rundown of a typical week. Yeah, I think that's it.
Does anyone have any clarifying questions for Peter? Lorena, because you'll be doing the case discussion, do you have a specific question for him?
Yeah, one of the questions that I have is, because the diet sounds pretty good, whether that's something new that he's just been doing recently, or how long has he been following the diet? Do we know?
I think that has been new within the past 3 months since the holidays. So in December, that's when his A1C was around 14. And he had a lot of dietary indiscretions at that point. And so I think starting then he made that change. And due to a miscommunication, we didn't make any changes to his insulin regimen between December and March. So that drop from 14 to 11, if it's due to any of his lifestyle changes, it's due to his change in diet, but not to do any changes in dosing of his insulin at all.
Okay. And the other question is, you mentioned that he was on steroids, but he's not on steroids anymore, right? Because I didn't really see it in the list. Okay. I don't have any other questions right now. Yeah. Does anybody have any other questions?
Yes, I was wondering about the diet, when I read the diet in terms of the number of carbs and the eggs that he seems to consume a lot of eggs. And I was just wondering, I saw that he met with the nutritionist, but has there been any follow-up regarding that?
He hasn't met with our nutritionist since 2018, even though he's been scheduled a couple times and canceled. So no, there hasn't.
Quick question. Do we know if his diabetes got significantly worse after he recovered from COVID from before the COVID?
He was not on insulin prior to COVID. That wasn't because he wasn't willing to. It looks, based on the hospital records, he had major hyperglycemia, almost like a DKA picture. And ever since then, he's had this insulin requirement.
Right. So with A1Cs that high, the one thing, and there's obviously a lot of reasons for that, but we're still learning about this post-COVID diabetes or post-COVID worsening diabetes for people with pre-existing diabetes. The receptor that the COVID virus binds to is actually on the beta cell. And the question is, how insulin deficient is this guy now? Even though he clearly is obese with this history of type 2 diabetes, my question is he still making insulin, and does he need a lot more insulin?
Great discussion there, Earl, to raise. There was one more question in the chat that was, because of his financial issues, how consistent do we think he is in taking his insulin? And especially because that may be a large barrier for him to regularly taking his insulin. Do you have any sense of that, Peter?
He's pretty straightforward with me about which medications he does and doesn't take. So I do think he's taking his insulin as prescribed. It was the Trulicity where he was just straight up, he was like, I can't afford that, so I'm not going to try or use it. Seeing some of this discussion, I don't think I've gone through all the hoops to get him that, but to answer your question, yeah, I think he has good adherence to his medications.
Great, that's good information to know. So I'm going to ask Lorena to start leading our case note presentation.
Yeah, totally. As a summary, so this is a 55-year-old Latino male with type 2 diabetes. He's obese, BMI is 43, I rounded up. He had severe COVID, pulmonary fibrosis, now in home oxygen. That is relevant because very likely his activity decreased, after this. He has hypertensive heart disease, but no CHF, high triglycerides, even if he is on a high dose of high potency statin. Microalbuminuria with a normal creatinine, and he has a history of a pulmonary embolism. So you have the list of medications there. These are the vital signs. So again, BMI is close to 43. These are the A1C, creatinine, and the lipid panel that I mentioned. The triglycerides are still high. As I mentioned, the history of COVID and the history of steroids, and now with pulmonary fibrosis, that very likely significantly decreases activity. Now he's on disability. And one of the questions, as Earl already asked, right, we should always wonder or ask ourselves this question, does this person produce insulin? Could this patient be type 1 or type 2? In this case, he has obesity. He clearly is insulin resistant. It's possible that he has type 2 diabetes. It is possible that his diabetes is very advanced now, and he might have also be insulinopenic. He is not on diabetic ketoacidosis, so he's not totally insulin deficient, but he clearly needs insulin to control his diabetes. Despite escalating doses of insulin, his control is not optimal. So the second question, really, is what is his A1C goal? After recognizing that A1C is really a marker that will help us for this individual patient, so comparing him with him. So then the A1C was 14 with some dietary modifications. It seems that it decreased to 11. 0.3, but what would be the goal in this case? Assuming that A1C is accurate, I would say that as long as he does not have hypoglycemia, I would be happy with an A1C that is less than 7.5. Now, if he could achieve an A1C lower than that with no hypoglycemia, then why not? Again, a lot of times, especially without a CGM, it's difficult to know. And I'll focus on non-pharmacological interventions first. First of all, when we have patients in whom we are increasing the insulin and we don't really see much improvement, we need to make sure that when we assess insulin use, like how much they are using, when, and how. So then not only assessing the doses of insulin, but when they are using their insulin. Are they given the insulin before eating? Sometimes they are doing it after. Or sometimes they are not doing the insulin if blood sugar is normal. Sometimes if they are eating something really healthy, they might not use their insulin. So then assessing how much, when, and how, and making sure that we also examine the sites. This is a patient with lipohypertrophy. I had several patients who kept injecting the insulin in the same spot. And one of them once mentioned, I use the same sites because it just doesn't hurt in these areas. Then the insulin was not being absorbed. And when we changed the sites, when we had a session about that, then that significantly improved insulin absorption and glucose control was better. Sometimes these very simple things make a big difference. We have also published some cases in our clinic. It is a diabetes clinic. We are diabetologists, and we still sometimes forget the very basics to review these very basics, how to use an insulin pen and so on. So then always kind of make sure that you review this with your patient. We also need to be careful sometimes how we ask about how patients are using insulin, because we do want the patients to be honest. We want to know what they are doing, how many injections. Some of the things I ask in a non-judgmental way, I just want to know, because I don't want to just increase the doses and actually my patient might not be using the insulin. Peter seems to have a very good relationship with this patient. Just also consider this when you are seeing your patients. Sometimes also when there is a language barrier, then it might not be entirely clear then how the patients are using their insulin, or they might not have a good understanding of how to use their insulin. I usually ask them, how many times a day do you inject your insulin? How many meals do you have a day? So if they say I have 3 meals a day and they're supposed to be on 3 injections a day, but then they tell me that they are only doing 2 injections a day, well, that will obviously triggers me asking more questions. I also use statements to normalize that sometimes we forget the insulin. And I want to know about that. How often do you think you might forget your insulin? When you are maybe out or visiting your family, you might not always have your insulin with you. How often does that happen? That will make the patients feel a little more comfortable and tell me, oh yes, every time I go to see my family, I sometimes forget, and so on. I also ask them, when your blood sugar is normal, what did you do? When you don't have your glucose meter with you, but you do have your insulin, so what did you do? Did you inject insulin? Because sometimes they might, or they might not. So sometimes they might just inject a very small amount, or they may not. So then all of these really will give you a good understanding of how they are using their insulin. I go through this even with the patients who I already know very well. And every time I ask my patients to tell me their doses, even if I just saw them a week ago, if they are really doing those doses, they very quickly will tell you. If I see that they are having difficulty remembering, then that's a little of a red flag that I should be asking a little more questions about their insulin use. The dose is very important. The timing is also very important. Sometimes they might give their insulin after eating when the blood sugar is normal, for example. If the blood sugar is normal, then they might eat and give their insulin afterwards. I do ask a lot of questions because I want to feel very comfortable that I know exactly what my patients are doing. As I mentioned, that diet of the patient seems pretty good. I would have more questions because I know, for example, Latinos, they use cactus leaf a lot. Sometimes we use, and that's good because it has a lot of fiber, but sometimes they might use that in shakes with pineapple or with other sugary juices, like with orange. So then I would ask about that is, how do you prepare it? How do you prepare that cactus leaf shake? It is actually a common recipe to have it with pineapple juice. And I praise them. These are very good options. These are very good choices. I think it's probably helping a lot with your diabetes and your blood sugars. Is it really hard to follow this diet? Because I want to see whether that's going to be sustainable, or I want to know what kind of difficulties they're having. If they tell me it is very difficult, then I want to have a backup plan or give some counseling. And we are very family oriented. Latinos family also is a lot of help. So I want to know whether they are on board. Is your wife helping with the meal preparation? Are they kids? And I would use that as a support mechanism as well. Then about continuous glucose monitoring. Then when I mention a target for an A1C, I always feel that as long as the patient does not have hypoglycemia, the lower they can go. So for that, I do need, especially patients on insulin, great tools. Good news is that continuous glucose monitors are now slowly but surely becoming more accessible for our patients. These are these 5 different Apple Health plans that we can use with Molina, Mary Group, CHPW, and United Healthcare pharmacy route. So you can send the prescription to the pharmacy, which is faster and more convenient than we use in medical supplier. Coordinated care still requires that we use a supplier for this, unfortunately, but with this we can use the pharmacy. I know that sometimes we need a prior authorization. Sometimes it's a lot of paperwork. It helps when we have in our notes and a good documentation of why the patient needs the CGM. So of course we need the diagnosis, right? The patients who are on intensive insulin management, basal bolus, like this patient. So this patient is on 4 injections of insulin a day, or maybe more, because sometimes they also use, with each meal and at bedtime. It's important to document that they are checking their blood sugars 3 times a day. If they have any evidence of glucose less than 50 in their meter, you can document that they have hypoglycemia unawareness. If they had low blood sugars overnight, you could also document that they have nocturnal hypoglycemia. I ask my patients whether they wake up in the middle of the night with low blood sugars or feeling anxious, sweaty, shaky, hungry. Sometimes they might not test. They might not test their blood sugar because they feel so unwell that they correct right away. So if that is happening, I also document that. And especially if it's happening overnight, I document that they are experiencing nocturnal hypoglycemia. Whether they have any complications, so if they have nephropathy, heart disease, if they have any dexterity issues, then it's harder for them to do finger sticks. Then a continuous glucose monitor would be more helpful. We need to establish that the patient is unable to achieve glucose control despite all of the above, despite being on 4 injections of insulin and testing and so on. Now, the requirements for Medicaid are with patients with type 1, patients with type 2, again, who are unable to have glucose control despite basal bolus and testing several times a day. I already mentioned this, relative blood glucose less than 50. And once the patient is approved for CGM, it is also very important to remind them that they need a visit at least every 6 months. Sometimes what happens is that the prescription is not continued because we didn't schedule a follow-up appointment every 6 months or so on. So to just be aware of that. Then that is for the non-pharmacological tips that I have. I don't know if there are any questions, Nicole, in the chat or any comments before I move on to the medical management.
We're running short on time, so why don't you move through to the medical management? Additionally, I think it's very important to highlight is that it's 3 or more injections for our Medicare population, and they've taken away requiring the 4 finger sticks a day, which is great. Hopefully we'll see more of that occur with our Medicaid population. One of the benefits of the pharmacy is that they're able to see that they're on multiple doses of insulin. So it usually helps facilitate the approval of it more rapidly because we know the paperwork can be challenging as a primary care provider.
Okay, so the medical management, Earl went through these nicely. So I'm going to try to be brief. The patient has cardiovascular disease. He does not have CHF. He does have microalbuminuria and he has obesity. So I would choose in this patient a GLP-1. But here, when we go through the algorithm of the guidelines, that's one of the first questions that you want to ask yourself when you are ready to prescribe something, whether they have cardiovascular disease, whether they have atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease, and then take it from there. How about you guys? Gail, what would you choose for this patient first? Would you choose GLP-1 or an SGLT2?
In terms of the weight, I would start off with the GLP-1, but I would also consider doing simultaneous a GLP-1 as well as an SGLT2 inhibitor, because I think you could benefit from both of them.
Yeah, I totally agree. I think this patient would benefit of both. Similarly, I think I would start with a GLP-1 and then with the goal of adding an SGLT2 later. And you will have these slides and you will have these tables, which are great, thanks to our pharmacist in our clinic. With Medicaid, Byetta and Bydureon are preferred, or Victoza in this patient, then I would start with Victoza because it has cardiovascular benefits, is better tolerated than Byetta and Bydureon. When it comes to, and again, you'll have these slides, Trulicity was not covered, so then we would have to use Victoza first with the goal of perhaps then changing to a weekly one, but the patient needs to try either Victoza or one of these two. When it comes to SGLT2 inhibitors, they are, Invokana for Shiga Jardians are all covered. The only one that is not is Stegrato. That's the only one that is not. These are the combinations of SGLT2 inhibitors and metformin. This patient is already on metformin. To simplify the regimen, when it's time to add an SGLT2 inhibitor, if that's what we opt to do, then considering a combination would be a good idea. We know that this patient is on insulin. So how are we going to adjust the insulin? We are going to add a GLP-1. How are we going to do this? Nicole is going to review this with you.
Thank you, Lorraine. I will be very brief, but I do think it would be great if you can stick around to hear about potential management plans for this patient. So in brief, how do we think about insulin? And as I said at the first session, I'm a weight-based calculator, but also one thing you want to do is look at their current total daily dose to get a starting spot. And typically what you want to do is you then divide the total daily dose into both the long-acting, our basal, and our prandial or our bolus insulin. We won't really talk that much about the correction factor, but it is really important to understand. A correction factor is if you give someone 1 unit of insulin, how likely are they to decrease, how much are they going to decrease their blood sugar? So for a really lean person, they might decrease their blood sugar 100 points, but for an insulin resistant like this person, it might be as little as 10 or 15 points. So that's really important to understand. When we're talking about it, it's also nice to be comfortable. What is a typical total daily dose for someone living with type 1 diabetes versus type 2 diabetes? So to focus on type 2 diabetes, people with type 2 diabetes may need more than 1 unit per kilogram. So again, it's what we are comfortable with as a starting dose and then titrating it. Unfortunately, there is no maximum dose of insulin. So sometimes it is a question of barriers to taking insulin, but sometimes it's a question of selecting the appropriate dose to see effect. And that's what we're always trying to do. We're trying to show the patients that and improve the diabetes, but also not increase the risk of hypoglycemia. Going to the next slide, very briefly, for this particular patient, right now, what do we know? We know, as Lorena pointed out, this person is fairly insulin resistant or very insulin resistant, likely because of their BMI of 42. From my estimate from their total daily dose of insulin, I thought they were on 40 of their basal insulin. And I was thinking they had been titrated up to 15 units with meals, but it sounds like the person is actually on 8 to 12. So that changes our estimate a little bit. They're probably on about 0.5 units per kilogram of insulin. So that's a good dose of insulin, but for someone with a BMI of 42, it might be that they need 1 unit per kilogram or more of insulin. So how would I be comfortable? We might not go up by this much, but I want you guys to understand that this is a predicted dose that I think we could get to on this potential patient. So I'm really happy with the basal dose right now. Right now it's at 0.3 units per kilogram, which is, we talked about in the last session, a good dose, but not a really high dose for risk for hypoglycemia. In someone with such a high BMI, definitely we could go up to 0.5 units per kilogram for the basal over time. But in this patient's case, I like to first work on the prandial control, and we're seeing the more of the need for the mealtime insulin than the background insulin, because we don't want to go up too much on the basal, and then if they are able to increase their activity, put them at risk for low blood sugars in between the meal. Although this person has a lot of limitations right now for their ability to exercise because of the post-COVID syndrome. I would actually preference thinking about using up to 0.5 units per kilogram divided in 3 doses. And so this might seem like a lot, but I predict this person could need up to 26 units per meal. It is just to put it in perspective. Then again, when we calculated the predicted sensitivity or correction, 1 unit would only drop them 14 points. So this is just knowledge. It doesn't mean that's what we're going to do, but it's like, oh, we might get there. And we need to be comfortable with insulin and large doses of insulin sometimes with patients. I would probably continue 40 units of basal. Now, this was based on the patient already being on 15 units, but I would probably be comfortable doing somewhere between 15 and 18, given what he's currently on, and even as high as 20 with the meal. Also, this is what the patient would be most comfortable with. So since they weren't taking 15 on a regular basis, you may just want to start at 15 with every meal and then increase it. Using a simple correction where you could do 2 units for every 30 greater than 150, so then you could really see how much additional insulin they're using as well. Now, a lot of times we don't do correctional insulin because it's too complicated, but this person seems to understand a basis of insulin and is taking his insulin. So that would be a possible choice in this patient. However, as Lorena has talked about, is we really want to use an insulin sparing agent with this person because of their heart disease at baseline. So what would I do for this particular patient? The goal is always to make their insulin management as easy as possible, and then also not create low blood sugars, but to get good effect and also to get heart benefit as well. So I, like Lorena said, would choose a GLP-1 receptor agonist. And to highlight again, unfortunately, the reason why Peter did not get the duglutide covered is because it wasn't the preferred insulin. So you really would start on liraglutide for this patient, which is a daily injection. One of the hardest things that has just recently occurred for our Medicaid patients in Washington State is that exenatide extended release is no longer on the market in the formula that is available for our Medicaid population. There was an older version where you had to shake it and reconstitute it, but it's not commercially available anymore. So there is a weekly exenatide that is available, but it's also expensive, so it's not a preferred thing. So you actually have to try now both liraglutide and exenatide twice a day before you can move to a weekly injection. And this, I think, has been very hard because it's always been you have to try 1 to 2 of the preferred agents, but now that we don't have a weekly one available, it's really a limitation to our Medicaid population. And we've been advocating for this change, but it has not occurred yet. So in this particular case, we would use liraglutide, and I would say that I would use a mixed insulin, so Humalog 70/30 or Novolog 70/30, so that it would be down to maintaining only 3 injections of insulin a day, 2 of insulin and 1 of an insulin sparing agent. I would say, given the fact that I already had him on 15 and he wasn't taking that, 85 units divided by 2 would be a great starting dose. So somewhere between 40 and 45 units twice a day would be okay. I had originally said, oh, we could go up to 100 units because that's a 20% increase given his A1C is over 9. So I might be as comfortable up to, given his BMI of 42, of 50 units twice a day, but you can always be conservative. So 35 to 40 units twice a day of a mixed insulin would be a good dose for him. And weekly titration of liraglutide, as well converting his metformin to twice a day and once a day, 2 tablets in the morning always makes it easy. And then the other highlight was, yes, the sitagliptin will need to be stopped if we are able to get him a GLP-1 receptor agonist. Then once his diabetes is better controlled, consider a sodium glucose cotransporter in the future, as Gail and Lorraine are both highlighted, because of both his heart, but also his renal disease. I'm going to leave this up here and ask Gail, do you have any particular management strategies, or what would you do? Anything different?
Well, I too believe in weight-based calculations, and it didn't seem like he was on too much insulin. So if we can increase the insulin dose, that is fine. I do agree that simplifying his regimen, but I also am concerned in terms of his weight. Sometimes that is something that we worry about. When you give more insulin, they gain more weight. It would be really important to get that GLP-1 receptor agonist on board, which may control that weight gain. So I would probably try to start that earlier on and then work with the insulin. And it seems as though there are some limitations in terms of the ones that you can use in Washington State. We're fortunate here in Washington, D.C. that pretty much all of the GLP-1s of the Medicaid population are covered, the once weekly ones, which I think improves adherence. I use that quite readily in our population, particularly when I'm very concerned about the weight gain.
Thank you, Gail. And Earl, are you still on with us? I know we're basically at 2 o'clock. So
Yes, you know what? I was just typing. My patient is here waiting, but I'm still here.
I was just going to ask if you had any final thoughts before we end session 2.
First of all, I want to thank you all. I agree, keeping it simple for somebody this insulin resistant, often keeping it simple with premixes. We don't think of it a lot, but it actually can be extremely effective. I believe that this may be one of the growing number of people we see. The reason why I ask about pre-COVID and post-COVID is that post-COVID, a lot of these people with new diabetes or worsening pre-existing diabetes, we are learning, and this is in evolution, that they have severe insulin deficiency. And it may actually be a different type of pancreatic diabetes, and we're still learning about it. I do think that C-peptide testing after the glucose toxicity is waned is worthwhile, because this may be an individual at higher risk of euglycemic DKA from an SGLT2 inhibitor. I hope that's not the case. I just know what we're all seeing around the country right now in these post-COVID patients.
Great point, Earl. That really brings us back to our current time and all the complexity of what we have to understand about patients living with cardiometabolic disease and diabetes. So with that note, this ends session 2 of the Cardiometabolic Echo. Thank you so much